So we're all familiar with coronary artery disease and being hardening of the heart arteries and with calcification. So this technique is really trying to use sodium fluoride, which of course we all know from toothpaste, binds to areas of calcification. Now, what the technique fundamentally does is it identifies areas of plaque that's actively calcifying. A high calcium score means the plaque is usually quite quiescent and it's healed. But when it's actively calcifying with the sodium fluoride being taken up, it usually means that the plaque is unstable. And when we've done histology studies and compared it with, for example, people who've died and looked at the tissue, the sodium fluoride tends to bind to plaques that have ruptured and burst and caused the initial heart attack. So what the technique is doing is identifying lipid-rich necrotic plaque that is highly likely to cause future problems and associated with causing heart attacks. So the preferred study, and the main findings were that if we use this technique, those that take up a lot of the tracer that have the hottest plaques are much more likely to have future events like heart attacks or dying of a heart attack. And in fact, dying of anything, it was able to risk stratify, so identify those that are most likely to come to harm after they've had a heart attack. So the next steps for this, I think, the purpose of this study actually was to validate this, because we'd shown it before in other populations, so we wanted to do it across the world and in multiple centres to show that it was generalisable. So we've achieved that. The next question is, well, what do you do with that information? So if I tell you that you're 2 to 3 times more likely to have a heart attack, what are you going to do differently? How are we going to prevent it? Well, I think revascularization is not what we're recommending here. What we're thinking is systemic therapies. So people are already on aspirin, statins and ACE inhibitors, beta blockers, but there are other drugs around that are very expensive, that may be more effective in people that have the hottest plaques. So things like PCSK9 inhibitors, drugs like canakinumab and other things like that, that dampen down inflammation. These might be drugs that we could now use in this selected group of patients. So we could use this as a way of selecting out those that are most likely to benefit from the drugs, but also the ones that are most likely to not then have a further heart attack. And finally, I suppose, if there isn't new drugs that are coming along, this technique could identify those that are most likely to have an event, so they could enrich the population for risk, but also use it as a marker. So if you give the drug and then the signal declines, then that might be a marker that the drug is really likely to work. So you could do that in small mechanistic studies as well to test out your new drug.